Welcome to the Rad Onc Smart Review Head and Neck Cancer series.
It is great to be back.
This is episode 37, Salivary Gland Four, Unresectable Disease and Advanced Approaches.
And, just to orient everyone, this one marks the completion of our salivary gland block.
Right.
We've really been building the foundation over the last few sessions.
We really have.
We covered that histology-driven biology back in episode 34. Then we looked at adjuvant RT triggers and planning in 35.
And most recently, that deep dive on perineural invasion strategy in episode 36.
Exactly. So the groundwork is laid.
It is. But today feels different. We're not talking about the standard post-operative cleanup anymore.
No.
Today, we are really addressing the nightmares. I mean, the patient who just cannot undergo surgery, the tumor that recurs despite everything we do.
And that classic ACC case that metastasizes to the lungs,
Yeah.
Years after you thought you'd won. These are the scenarios that, frankly, keep radiation oncologists up at night. And they're the ones that board examiners love to test because they require real judgment, not just memorization.
Right, you can't just look up a nomogram for these cases.
Not at all. You have to understand the anatomy, the radiobiology, and crucially, the systemic options.
And we're going to cover a rapidly evolving area, which is that biomarker-driven systemic therapy. This used to be, a footnote, and now it's practically the headline.
It is absolutely critical.
Yeah.
This is where salivary gland oncology is changing the fastest. If you're operating off data from 5 or 10 years ago, hell, even 3 years ago, you were already behind.
And the board examiners know it.
They absolutely know it, and we need to make sure you know it too.
So let's complete this block. Our mission today is clear. We're going to tackle unresectable disease, recurrent tumors, and metastatic management. But, as always, let's anchor this in a real-world scenario.
Let's get right into the case.
Okay, picture this. You're in clinic. It's a Tuesday afternoon. You have a 62-year-old man on the schedule. He presents with a right parotid mass.
Okay.
Now, this isn't something that just popped up over the weekend. It has been growing for 18 months. He basically ignored it, hoping it would go away.
Which they so often do.
Until he developed progressive right facial weakness over the past 3 months.
Oof. That is already a massive red flag.
A huge one.
We always say this, but it bears repeating. Progressive facial weakness in the setting of a parotid mass is malignancy until proven otherwise. A benign pleomorphic adenoma generally just pushes the nerve. It doesn't eat it.
Right.
When you see that function loss, you have to assume invasion.
Exactly. So on examination, he has a fixed rock-hard mass in the right parotid region. And when you check his facial nerve function, he has complete right facial paralysis. We're talking House-Brackman grade 6.
Wow. So nothing's moving?
Nothing is moving. The eye isn't closing. The corner of the mouth is drooping. It's total paralysis.
And I assume you palpated the neck. Because with a high-grade process like that, you have to worry about regional spread.
We did. And there is palpable, firm adenopathy at level 2.
Okay, so clinically, we're dealing with a locally advanced, likely high-grade malignancy, just given the nerve function and the nodal spread.
Yeah.
We need to define the extent. So what does the imaging tell us about the anatomy?
The MRI shows a 5-centimeter mass in the right parotid. But here's the kicker, and this is why we are discussing it today. It shows direct invasion into the skull base at the stylomastoid foramen. It is actively encasing the petrous internal carotid artery, and it extends right into the infratemporal fossa.
Okay.
There's also a 2.5-centimeter level 2A node.
That encasement of the petrous internal carotid, that's the critical detail right there.
That's the one.
That is the stop sign for the surgeons. That is going to dictate the surgical resectability or, the lack thereof. If you try to pull that off, you are risking a catastrophic stroke or bleed.
Right. What about distant staging?
You got to check.
CT chest shows 3 small pulmonary nodules. The largest one measures 8 millimeters.
Okay, so we've got a diagnostic dilemma there too. Is it M0 versus M1? Is this metastatic? Or is it just, granulomas or some old infection?
And the pathology.
Let's hear it.
Biopsy confirms salivary duct carcinoma, high grade.
High grade salivary duct carcinoma. You should basically think of it as the breast cancer of the salivary world. It's very aggressive, high propensity for distant spread, and very rapid local growth.
So you send him to the head and neck surgeon. The surgeon reviews the imaging, looks at the carotid flow voids being pinched, and tells you plainly, this is T4B. I cannot get an R0 resection without unacceptable morbidity. I'd have to sacrifice the carotid. He needs definitive radiation.
And there it is. That's the clinical question right in front of us. How do you approach unresectable salivary gland cancer? And just as importantly, what in the world do you do about those suspicious lung nodules?
Before we unpack all the data, let's put this into a 60-second board script. You're sitting in that exam room, the clock is ticking, the examiner is just staring at you.
Yeah.
How do you synthesize this?
All right. Deep breath. Clock starts now.
Go.
This is a 62-year-old man with salivary duct carcinoma of the parotid, T4BN1, with skull base invasion, carotid encasement, and suspicious pulmonary nodules. The tumor is unresectable, defined as skull base invasion, carotid encasement, or inability to achieve R0 without prohibitive morbidity.
And your plan?
My approach begins with tissue confirmation of the lung nodules to establish whether this is M1 disease. If metastatic, I order comprehensive biomarker testing androgen receptor, HER2 and TRK fusions, and TMB, because for metastatic salivary cancers, the first treatment is the biomarker panel. Salivary duct carcinoma is approximately 90% AR positive, and combined androgen blockade achieves around 42% objective response rate.
And if it's M0?
If the lung nodules are benign, and this is M0 disease, I recommend definitive IMRT to at least 70 gray to gross disease, with concurrent consideration of systemic therapy in a clinical trial setting. I counsel that RT alone cures only approximately 20% of advanced stage salivary tumors, but meaningful local control is achievable. Long-term surveillance will include chest imaging, given the high risk of late distant metastases.
Perfect. Concise, covers the biomarkers, covers the dose, and sets those realistic expectations. Now let's peel back the layers here. Let's start with that concept of unresectable. It feels like a moving target sometimes.
It can be, but for the boards and, for safe practice, we need to be very clear about when we pull the trigger on definitive radiation. Because in salivary gland cancer, surgery is usually king.
Oh, yeah.
If you can cut it out, you cut it out. The control rates are just vastly superior with surgery, followed by radiation compared to radiation alone.
So unresectable T4B disease is the primary indication, but what does that actually mean anatomically?
Right, it's not just about size. You can have a huge tumor that is, exophytic and easily resectable. Unresectable generally refers to specific no-fly zones. This includes invasion of the skull base, encasement of the internal carotid artery, or deep extension into the infratemporal fossa, where you simply cannot get around the tumor to get a clear margin.
That prohibitive morbidity phrase you used in the script, that's really the key, right?
It is. I mean, technically, a surgeon could remove almost anything if they didn't care about the patient surviving the procedure or having a facelift afterwards.
Right.
But if achieving a negative margin requires a surgery that leaves the patient with an unacceptably poor quality of life, or if the risk of stroke or death on the table is too high, it's deemed unresectable. That definition matters. Examiners want to hear the specific anatomic reasons surgery isn't feasible.
You can't just say it's big.
You can't just say it's big. You have to say it's encasing the carotid.
Like in our case, the encasement of the petrous internal carotid artery.
Exactly. You cannot just carve the tumor off the carotid safely in that location without risking a blowout or a stroke. The morbidity just outweighs the benefit of the resection, especially since you'd likely leave positive margins anyway.
What about medically inoperable patients?
That's the second group. And these are patients who might have a resectable tumor anatomically, but physiologically, they simply cannot tolerate general anesthesia.
Okay.
Maybe they have severe heart failure, severe COPD, or they're on anticoagulation that just can't be reversed. The cardiopulmonary comorbidities make a major head and neck surgery way too risky.
And then there's the third scenario, patient refusal.
And this happens more than you might think. We have these long informed consent discussions about functional outcomes. We tell them, to get this cancer out, we have to sacrifice your facial nerve. You will never smile on this side again. You won't be able to close your eye. You might need a gold weight in your eyelid.
And some patients hear that.
And they just say no.
Yeah.
They decline the surgical approaches. They prioritize function over cure probability.
And finally, gross residual disease. This is kind of the oops category.
Right. This is when a surgeon attempts a resection. Maybe they thought it was resectable on imaging, but they get in there and realize they cannot achieve negative margins. They leave gross tumor behind. And if re-resection isn't feasible, we then convert to a definitive treatment paradigm. We're no longer doing adjuvant therapy. We're treating gross disease.
I want to look at the NCCN pathway here. For T4B disease, it states explicitly, no resection possible or resection not recommended. The options are definitive RT or systemic therapy with RT.
And notice that systemic therapy with RT is category 2B. We'll get to that trap later.
Yeah.
It is not the same slam dunk category 1 recommendation you see in squamous cell carcinoma.
Before we get to the technique, we have to talk about the outcomes. I feel like this is the hard truth segment of our talk today. We need to manage everyone's expectations here.
It is. And I need to give you the honest data because examiners will test whether you understand the limitations of what we do. You cannot go in there promising a 90% cure rate with radiation alone for a T4 tumor. That's malpractice.
Right.
We have to reference the classic Mendenhall review from Cancer in 2005. This is the paper everyone cites.
They compared definitive RT versus surgery plus postoperative RT. What did they find?
The findings were pretty sobering. For early stages 1 through 3, local regional control was 70% with RT alone versus 89% with surgery plus RT.
That's already a significant gap.
It is a big gap.
That's a huge drop, nearly 20 points. What about stage 4? That's usually what we're dealing with in these unresectable cases.
Well, for stage 4 disease, local regional control was only 24% with RT alone versus 66% with surgery plus RT.
Only 4%. So that means 3 out of 4 patients are going to fail locally?
Exactly. The bottom line is that RT alone cures only approximately 20% of patients with advanced stage salivary gland malignancies. It just struggles against the bulk of the disease, the hypoxia, and the inherent radioresistance of these histologies.
That is a tough number to hear. How do you even present that to a patient? I have a treatment for you, but it probably won't work.
Well, you have to be honest, but this does not mean definitive RT is futile. Remember, control and cure are different things. Meaningful local control can be achieved in selected patients, sometimes for years. We can stop the bleeding, stop the pain, prevent the tumor from fungating.
Okay.
And for truly unresectable disease, it remains our best option. But you must counsel patients honestly about the inferior outcomes compared to surgical approaches.
So a board-safe statement would be something like, definitive RT is reserved for unresectable T4B disease, medically inoperable patients, or those who refuse surgery after informed consent. Outcomes are inferior to surgery plus adjuvant RT, approximately 20% cure rate for advanced disease, but meaningful local control can be achieved in selected patients.
That is the perfect way to frame it. You show you know the data, but you also show you are not giving up on the patient. You are offering the best available therapy in a bad situation.
Okay, let's talk technique. If we're going to do this, we have to do it right. We're swinging for the fences here. We need to deliver a dose that has a chance of sterilizing this tumor. So what's the one-liner for the boards regarding dose and planning?
Okay, here is your one-liner. Definitive IMRT, or protons, to 70 gray to gross disease, with SIB to 63 gray high-risk subclinical and 54 to 56 gray elective, plus skull-base nerve tracking when indicated per episode 36 principles.
Okay, let's unpack that. Start with the dose prescription per NCCN. Why 7?
For high-risk volumes, meaning gross tumor and involved lymph nodes, the dose is 66 to 70 gray at 2 grays per fraction. And why 70? Because salivary tumors are notoriously radioresistant. You need a very high biological effective dose to sterilize gross disease.
Yeah.
This is delivered daily, Monday through Friday, over 6 to 8 weeks.
Right.
If you stop at 60 grays, like we might for some lymphomas or microscopic disease, you are almost guaranteeing recurrence in gross salivary disease.
And for intermediate risk?
These are the sites of suspected subclinical spread, immediately adjacent to the tumor. The dose there is 54 to 63 gray at 1.6 to 1.8 gray per fraction. This is usually done with a simultaneous integrated boost, or SIB.
And then low risk?
For low-risk elective volumes, the dose is 44 to 50 gray at 2 grays per fraction equivalent. This covers the elective neck nodes that aren't touching the tumor but are still at risk for microscopic spread.
Now, regarding planning principles, IMRT is pretty much always preferred, right?
Yes. 3D conformal RT is technically acceptable in the guidelines, but practically IMRT is vastly preferred. I mean, think about the anatomy. You're trying to put 70 gray into the parotid bed.
Yeah.
The brainstem is millimeters away. The cochlea is right there. The oral cavity, the temporal lobe. They're all right there. You really need those steep dose gradients that only IMRT or VMAT can provide to carve the dose away from these critical structures.
So when do we consider protons? Is that just a luxury, or is there a real indication here?
Proton therapy is a very real consideration when photon constraints can't be met, or when photon-based therapy causes a compromise of the standard dosing to the tumor volumes.
This sounds particularly relevant for our case today.
Absolutely. Think about our patient. The tumor extends to the skull base. We have brainstem, temporal lobe, and optic pathway constraints that become very, very limiting. With photons, you have that exit dose bath. The beam goes through the tumor and exits out the other side, potentially hitting the brain. Protons have the Bragg peak. They deposit their dose, and then they stop, so they can spare that integral dose to the brain and normal tissue much better than photons in some of these deep skull-based geometries.
So if you can't get 70 grays in with photons...
If you can't get 70 grays in without burning the brainstem, you send them for protons.
We also need to mention nerve coverage. We did a whole discussion on this, but give us the recap for the definitive setting.
Right. We follow the principles we laid out in episode 36. For clinical or radiographic perineural tumor spread, which our patient definitely has with the facial paralysis, you have to track the involved nerve toward the skull base. For a named nerve involvement, you extend the CTV to the appropriate foramen.
So in this case,
this stylomastoid foramen, and likely up the fallopian canal, you treat the nerve path as if it were tumor, because microscopically it probably is.
And for xerostomia, we're blasting the parotid, so that gland is pretty much toast.
Correct. When the ipsilateral parotid is the tumor site, it is lost. Do not try to spare it. You will underdose the tumor. Your priority becomes the contralateral parotid mean dose, keeping it to 25 gray or less.
And the submandibulars.
And keep the submandibular glands mean dose less than 39 grays if possible. That's your only hope for preserving some salivary function. If you destroy all 4 major salivary glands, the patient's quality of life takes a massive, massive hit.
Now, historically, there was this huge debate about photons versus neutrons. Are we strictly using photons now?
In the modern era, yes. Photon-based IMRT is the practical standard. But we could look at the data supporting that, because there was a time when neutrons were thought to be the magic bullet.
Right.
A radiotherapy and oncology study from 2014 examined 27 patients with unresectable salivary gland tumors treated with IMRT, or 3D conformal RT, to a median dose of 70 gray.
All right, and what were the results?
2-year local control was 69%, 5-year local control was 55%.
That's better than the 20% cure rate we just mentioned from the Mendenhall review.
It is a selected series, but yes. It shows that with high-quality IMRT, we can achieve decent control. But, importantly, late grade 3 toxicity occurred in only 11%.
Which is a huge improvement over the neutron data, which we'll get to in a minute.
A massive improvement.
So the board statement here is, IMRT to at least 70 gray is an acceptable alternative to neutrons for unresectable salivary gland malignancies, with 2-year local control of approximately 65 to 70% in selected series and significantly lower late toxicity.
Correct. That's the safe, evidence-based answer. It acknowledges that while neutrons might kill more tumor, the toxicity profile of modern IMRT makes it the preferred initial strategy for most patients.
Before we move on to neutrons, what about concurrent chemotherapy? I mean, if this was a squamous cell carcinoma, we would be adding cisplatin without thinking twice. We have endless phase 3 data for that.
Careful. This is a trap. For salivary gland malignancies specifically, the ASCO guidelines state that concurrent chemotherapy may not be routinely offered outside a clinical trial.
But the NCCN lists it as an option.
They list systemic therapy with RT as category 2B. And that means there's non-uniform consensus based on lower-level evidence. We just don't have the big phase 3 trials showing a survival benefit like we do in squamous cell. The biology is different.
Right.
Cisplatin works well in squamous cell. It doesn't seem to add much punch in salivary cancers like ACC or salivary duct.
So what's the board's safe approach?
You say. For unresectable salivary gland malignancies requiring definitive RT, I would discuss concurrent systemic therapy in a multidisciplinary setting, but I recognize this is category 2B and not standard practice outside clinical trials. I would prioritize clinical trial enrollment if available.
Got it. Don't be a cowboy with chemo. Okay, let's do a brief history lesson. Neutron therapy. Why do board examiners still ask about this if it's basically gone?
Because it represents a really important chapter in understanding radiobiology. And it explains why we treat the way we do now. It's the perfect example of theory versus reality. It highlights the difference between killing a tumor cell and curing a patient.
So what was the theory? Why were neutrons so attractive?
Well, salivary tumors, especially adenoid cystic carcinoma, have very long doubling times. They're slow growing. And that makes them theoretically radioresistant to conventional photons, which rely heavily on the cell cycle.
Right, photons damage the DNA.
And the cell usually dies when it tries to divide. If the cell doesn't divide for a long time, it can repair that damage and survive.
And neutrons are different.
Totally different. Neutrons are high LET radiation. LET stands for linear energy transfer. They have a relative biological effectiveness, or RBE, greater than 2.6.
Okay, let's break that down for the listener. What does high LET actually mean for the DNA?
Think of photons like a sniper rifle. They make precise, single-strand breaks. The cell has repair mechanisms to fix these. Now think of neutrons like a cannonball. High LET radiation causes these dense ionization tracks. It creates complex double-strand DNA breaks that are very, very hard to repair. It just smashes the DNA structure.
Basically, it's a sledgehammer.
Exactly. It's less dependent on cell cycle phase and less dependent on tumor oxygenation. So for slow-growing hypoxic tumors, which many large salivary tumors are, it has a massive theoretical advantage.
And the data back that up, right? At least for tumor control.
In terms of tumor control, yes, unquestionably. You look at RTOG 8001 and the MRC trial. These were published back in 1988 and 93. They randomized patients to photons versus neutrons.
Yeah.
2-year local regional control was 17% with photons versus 67% with neutrons.
That is a huge difference. 17 versus 67. That's just undeniable efficacy. That looks like a home run.
It was dramatic. 10-year local regional control was 17% versus 56%. The neutrons were incredibly effective at sterilizing the tumor bed.
But there was a cost. A massive cost.
A terrible cost. Severe late complications occurred in 15% of photon patients versus 69% of neutron patients.
69% severe late toxicity. That's unacceptable.
It's profound. We're talking about tissue necrosis, bone necrosis, severe fibrosis, where the neck basically turns to wood. Patients would lose their jaw, or have carotid blowouts, or have these severe non-healing ulcers.
Wow.
And interestingly, the pattern of failure shifted. With photons, local failure was the problem. With neutrons, because local control was so good, distant metastasis became the dominant failure pattern. Patients live long enough to die of lung mets, but they live with terrible toxicity.
So where does that leave us today?
Fast neutron therapy is now effectively limited to a single program in the United States, the University of Washington. NCCN acknowledges the historical promise, but notes the extremely limited availability. So for practical purposes, definitive IMRT or proton therapy are the modern standards. We trade a bit of local control for a massive reduction in severe late effects.
So on boards, acknowledge the history, know the toxicity numbers, but stick to IMRT.
Precisely. Don't recommend a treatment the patient can't get, or one that carries a 70% risk of a major injury.
Let's pivot to histology. We have to talk about adenoid cystic carcinoma, or ACC, and the distant metastasis problem. This connects right back to those lung nodules in our case.
This is one of the most important concepts in salivary gland oncology. It really separates residents who understand the disease from those who just do not.
I've heard ACC described as a long con histology.
That is a perfect analogy. It is the long con. It's indolent, meaning it grows very slowly, but it is incredibly persistent.
Yeah.
You can achieve 90% or better local regional control with surgery and adjuvant RT. The patient looks cured.
But
But that doesn't mean you've cured the patient.
instead of distant mets.
Right. 30 to 40% of ACC patients eventually develop distant metastases, and these can occur years or even decades after the initial treatment.
Where do they go?
A lung is by far the most common site, followed by bone and liver,
And why is the rate so high if the local control is so good?
because it spreads hematogenously through the bloodstream rather than through lymphatics. This is why nodal metastasis rates are quite low, only 5 to 8%. But distant metastasis rates are high. The seeds are often planted before we ever start treatment. They just sit there, dormant, for years.
Actinic cell carcinoma behaves similarly, right?
Yes. A cynic cell also shares this long con behavior. The 5-year overall survival is approximately 90%. So everyone high fives at the 5-year mark.
Right.
But the 20-year overall survival drops to 55%. These tumors recur or present with distant mets 20 years later.
What does this mean for surveillance? Usually we discharge H&N patients after 5 years. We tell them, congrats, you made it.
Not here. It means you are married to this patient for life. Per ASCO guidelines, surveillance should include a chest CT annually, especially for ACC.
Annually? For how long?
Indefinitely.
Mm.
Lifelong surveillance is mandatory. A patient who is disease-free at 5 years is not cured. They remain at risk for the next decade and beyond.
How do you explain this to a patient without just terrifying them? Hi, you're cured, but see you next year forever because it might come back.
You have to be honest, but also reassuring, I tell them. Adenoid cystic carcinoma behaves differently. Even after successful treatment, there is a risk around 30 to 40% of it appearing in the lungs years later. That is why we check your chest every single year.
And the reassurance?
The reassurance is that even if it appears in the lung, it often grows very, very slowly. Some patients live many years, even a decade or more, with metastatic disease. It is not a death sentence the way lung mets from other cancers might be. We have patients who play golf every week with 10 nodules in their lungs, and they feel totally fine.
That brings us perfectly to the next topic, modern systemic therapy. Because if we find those mets, we need to know what to do.
And this is the area of salivary gland oncology that is changing the fastest. This is where you could demonstrate a really sophisticated understanding on your boards.
What's the key concept here?
The key concept is this. For metastatic salivary cancers, the first treatment is the biomarker panel.
Why? Why not just start chemo?
Because targeted therapy response rates can dwarf cytotoxic chemotherapy. Traditional cisplatin, doxorubicin, it's just not very effective here. The response rates are low, toxicity is high, but targeted agents, they can be absolute game changers.
The NCCN explicitly recommends next-generation sequencing. So let's walk through the actionable biomarkers. Start with androgen receptor, or AR.
This is the salivary duct carcinoma story, just like our patient today. Salivary duct carcinoma resembles high-grade breast invasive ductal carcinoma histologically, and just like breast cancer, it is often hormone receptor driven.
And how many are AR positive?
Approximately 90%. That is a huge number. And the male-to-female ratio is 4:1, which reflects this AR biology.
So if it's AR positive, what do we use?
Combined androgen blockade, usually leuprolide plus bicalutamide. It's the same stuff we use for prostate cancer.
And does it work?
The prospective phase 2 data shows an objective response rate of approximately 42%. That is meaningful activity, especially when you compare it to cytotoxic chemo, which might give you 15 or 20% if you're lucky. And the toxicity profile of hormone therapy is generally much better.
Okay, next biomarker, HER2.
HER2 amplification is found in a subset of salivary duct carcinomas and also high-grade mucoepidermoid carcinomas.
And the treatment?
Trastuzumab combined with docetaxel. Reported objective response rates are approximately 60 to 70%.
60 to 70%. That is transformative. That's taking a lethal disease and turning it chronic.
It absolutely is.
Now for the one that has everyone excited, NTRK fusions.
This is the success story. You cannot afford to miss this one. NTRK gene fusions are found in a subset of salivary tumors, most commonly secretory carcinoma.
This used to be called mammary analog secretory carcinoma, right?
Correct. It's a relatively indolent histology. But if it metastasizes and it has an NTRK fusion, the drugs are larotrectinib or entrectinib.
Hit me with the number.
In TRK fusion salivary gland tumors specifically, larotrectinib has reported objective response rates of approximately 92%. 92%. That's unheard of. It is among the highest response rates in all of oncology. If you miss this biomarker, you are denying the patient a drug that works 9 times out of 10. If a resident tells me they ordered cisplatin for a metastatic secretory carcinoma without checking NTRK, I'm failing them. You are missing a home run.
That is a mic drop statistic. What about immunotherapy, TMB and MSI?
Checkpoint inhibitors like pembrolizumab have a role, but it's more limited. In unselected patients, the activity is pretty modest. But if the tumor is TMB high defined as 10 or more mutations per megabase or MSI high, then pembrolizumab is appropriate per the FDA tumor agnostic indication.
So you have to test to find those candidates.
Exactly. Most are not TMB high.
Yeah.
But for those that are, it is a valid option.
Finally, what about ACC specifically? Is there a drug for that?
There is emerging data for axitinib. It's a VEGF receptor tyrosine kinase inhibitor.
And what does the data say?
In a randomized phase 2 trial, axitinib improved progression-free survival significantly. 10.8 months versus 2.8 months for observation.
That sounds great.
It is good, but you have to look at the objective response rate. It was only approximately 3%.
3%. So the tumor didn't shrink?
No. Axitinib is a stability drug, not a shrinkage drug. It slows progression and maintains disease control. And given ACC's indolent nature, that stability is valuable. But do not promise shrinkage to the patient. You are buying time, not melting tumor.
Right.
If the patient has painful, bulky mets pressing on a nerve, axitinib probably won't help with the pain quickly.
Okay, let's talk about managing recurrent disease. What happens when the cancer comes back locally?
It depends heavily on their prior treatment. If they've had no prior RT, and the recurrence is resectable, you do surgery followed by adjuvant RT. That's pretty straightforward.
But what if they have had prior RT?
That is where things get very difficult. If it's resectable, surgery is strongly preferred. You want to avoid the toxicity of re-irradiation if you can.
And if it's unresectable and they've had prior RT?
Then you're looking at re-irradiation. But NCCN puts a big caveat here. Clinical trial preferred.
Why is re-irradiation so dangerous here?
Because of the cumulative dose, you have to check the spinal cord, the brainstem, and the carotid. There's a very high risk of carotid blowout or severe necrosis. Generally, we want a minimum interval of 6 months, preferably 12 months, from the prior RT. And you need a dose of at least 60 grays if you're aiming for cure.
It's a high-stakes situation.
It requires a multidisciplinary discussion every single time. And often, hyperfractionation or protons are brought back into the discussion to try and spare normal tissue.
Yeah.
But you must warn the patient about the very real risks of severe complications.
Let's apply all of this back to our case. Remember our 62-year-old man, salivary duct carcinoma, T4BN1, carotid encasement, 3 lung nodules.
Right. Let's finish this story.
Step 1 was tissue diagnosis of the lung nodules.
Essential. We need a CT-guided biopsy of the largest lesion. We have to know if we're dealing with stage IVB or stage IVC.
Step 2, biomarker testing.
Yes. And regardless of the lung biopsy result, we're testing the primary biopsy for AR, HER2, and TRK and TMB.
Okay, scenario A. The biopsy confirms metastatic salivary duct carcinoma.
This is stage 4C. If he's AR positive, which is 90% likely, I initiate combined androgen blockade with nuprolide plus bicalutamide.
And the primary tumor, the big parotid mass that's paralyzing his face.
The local therapy would only be for palliation. If he has severe pain or, impending airway compromise, we might treat it, but we aren't trying to cure the primary if he has distant mets. We treat systemically. We don't want to subject him to 6 weeks of high-dose radiation and toxicity if his lifespan is limited by the metastatic disease.
Okay, scenario B. The lung nodules are benign.
Then we are in the definitive RT paradigm. I would plan definitive IMRT to 70 gray to the gross disease. I'd use an SIB technique, giving 63 gray to high-risk subclinical regions and 54 gray to the elective volumes.
Any special contours?
I would cover the facial nerve pathway all the way to the stylomastoid foramen, given his clinical nerve involvement. And I'd be very, very careful with the brainstem constraints.
And counseling.
An honest discussion. Radiation is our best option for local control. It cures about 1 in 5 patients long-term. It is not as good as surgery, but surgery isn't safe for you. We will also test your tumor for markers in case we need targeted meds in the future.
Let's touch on toxicity briefly. We know the acute staph mucositis, dermatitis, xerostomia, but tell me about the late effects, the price of high-dose RT.
The historical neutron data showed us the ceiling of toxicity, but even with IMRT, the risks remain. Cranial neuropathy can occur, delayed palsy years later. Temporal lobe necrosis is possible if your skull base coverage is high.
And the bone.
Osteoradia necrosis of the mandible, and trismus fibrosis of the pterygoid muscles. If you fibrosis the pterygoids, the patient can't open their mouth. This severely impacts eating and speech.
And with carotid encasement.
Carotid stenosis or even blowout. And that's a critical conversation to have with the patient. The tumor is wrapping your main artery. The radiation will weaken that artery further. There is a risk of stroke.
Before we get to the quiz, let's hit the board traps. What are the 3 things that will fail you on this topic?
Okay, trap 1. Recommending definitive RT without acknowledging the inferior outcomes. If you say it's just as good as surgery, you fail. You must quote the 20% cure rate.
Trap 2.
Failing to order biomarker testing for metastatic disease. If you miss the NTRK 92% response or the AR options, you're practicing outdated medicine.
And trap 3.
Reflexively ordering cisplatin.
Salivary glands are not squamous cell carcinomas. Standard cytotoxic chemo is poor. Prioritize biomarker-driven therapies or clinical trials.
All right, are you ready for the board blitz? I have 3 questions for you.
Bring them on. Question 1. A 65-year-old man has a T4B parotid adenoid cystic carcinoma with skull base invasion encasing the internal carotid artery. The tumor is deemed unresectable. What is your recommended treatment approach and expected outcome? A. Definitive RT to 60 gray with expected 2-year local control greater than 80%. B. Definitive IMRT to at least 70 gray with expected 2-year local control approximately 65 to 70% in selected series. Counsel on inferior outcomes versus surgical approach. C. Chemotherapy alone with cisplatin and 5-FU, Or D, best supportive care given poor prognosis?
The best answer is B. For unresectable T4B salivary gland malignancies, definitive IMRT to at least 70 gray is the standard. That Radiotherapy and Oncology 2014 series showed 2-year local control of 69%. Option A is wrong because 60 gray is too low for gross disease. C is wrong because chemo alone is ineffective. And D is premature.
Question 2. A 58-year-old man with metastatic salivary duct carcinoma to lung and bone has failed first-line observation. What biomarker testing should guide your next treatment recommendation? A, PD-L1 expression only, B, EGFR mutation analysis, C, androgen receptor status, HER2, NTRK fusions, TMB, or DBRCA1 and BRCA2 germline testing?
The answer is C. Salivary duct carcinoma is 90% AR positive. You need the full panel: AR, HER2, NTRK, and TMB. This guides your choice between androgen blockade, trastuzumab, larotrectinib, or pembrolizumab.
Question 3. A 52-year-old woman with adenoid cystic carcinoma of the submandibular gland completed surgery and adjuvant RT 8 years ago. She now has 3 small lung nodules, the largest measuring 1.2 centimeters, confirmed as metastatic ACC on biopsy. He is asymptomatic with excellent performance status. What is the most appropriate initial approach? A, immediate systemic chemotherapy, B, expectant management with surveillance imaging, C, palliative RT to lung nodules, or D, hospice referral?
The answer is B, expectant management. ACC lung metastases are often incredibly slow-growing. Patients can live for a decade with them. If she's asymptomatic, you observe. If she progresses, you consider local therapy or systemic options later. Do not rush to toxicity.
Fantastic.
That covers it.
Let's look forward. This completes our salivary gland block. I mean, over 4 episodes, we have built a massive framework.
We really have. We started with histology in episode 34. We covered adjuvant triggers in 35. We did perineural invasion in 36. And today, we handled the heavy hitters, unresectable disease, and biomarkers.
In episode 38, we begin the sinonasal block. We'll be talking anatomy, that histologic diversity, and the unique planning challenges of tumors adjacent to the orbit and skull base.
I'm really looking forward to that.
Let's wrap up with a quick recap of the key learnings from today.
Okay. Pearl 1. Definitive RT requires at least 70 gray IMRT for unresectable disease. But you have to remember the cure rate is only about 20%.
Pearl 2.
Pearl 2. Neutrons are a history lesson. Great control, terrible toxicity.
Pearl 3.
ACC is the long con, look for lung mets years later.
Pearl 4.
Metastatic treatment starts with the biomarker panel.
And the big one, Pearl 5.
Don't miss NTRK. A 92% response rate is just too good to ignore.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.